Good morning, everybody. I'm Annalisa Patriarca, Accelerator Engineer from Institute Curie Hospital, France, and I would like to thank the organizer to allow us to perform these presentations in virtual format and for inviting me to talk about a hot topic in the medical application of accelerator, the flash radiation therapy, accelerator aspects. First of all, a few words about cancer care with radiotherapy techniques. Most of the 95% of the treatments are realized with linear accelerators delivering megavoltage photons or electrons of less than 20 MeV. The machines are combined with multi-leaf collimators to shape the beam according to the tumor size and imaging devices for positioning the patient. A treatment consists in delivering a total dose between 40 and 70 gray, depending on the cancer, irradiating 5 times a week with a dose per session of around 2 gray. As a reminder, the gray is defined as the absorption of 1 joule of radiation energy per kilo of matter. So, in terms of beam fluence, it is the product of the fluence and the mass stopping power. The dose rate is in the range of 30 to 70 milligray per second, and the field size can go from few centimeters up to 40 centimeters square. The limitations of these cancer techniques are represented by the maximum dose that can be delivered without secondary effects on the healthy tissue surrounding the tumors. There are some strategies to overcome these limitations, improving the treatment outcome. We can induce a more efficient irradiation of the tumor using hadron therapy, so choosing different kind of particle and energy, or with the targeted radiotherapy, or using biological radiotherapy like immunotherapy, or by improving the imaging devices. Or we can preserve the healthy tissues. This strategy optimizes the dose delivery methods by a special modulation of the dose using small beam sizes, or with a temporal modulation of the dose with high dose rates higher than 40 gray per second. We can play on physical parameters to induce a different biological effect. In 2014, a group led by Professor Favodon from Institute Curie reported that ultra-high dose rate flash irradiation increased the differential response between normal and tumor tissue on lung mice irradiated with dose higher than 15 gray in less than 500 milliseconds, with a mean dose rate higher than 40 gray per second. They showed also the same anti-tumoral efficiency that a conventional irradiation dose rates that are in the order of 1,000 times lower. Here you can find in imaging the sparing of the healthy tissues that a flash irradiation has with respect to a conventional irradiation, particularly at 17 grays that are known to induce fibrosis in mice following conventional dose rate. Flash irradiation spares lung, and for his effect on tumor grafts, the flash proved to be as efficient as conventional irradiation to cure tumors. Since this moment, several groups started to work on this promising new radiotherapy technique, as you can see from this recent review of 2019. In the table below, there are summarized all the in vivo studies of flash response for various normal tissues, particularly on mice, intestines, foot skin, tail skin, lung and brain, but also for mini pig and cat skin. In particular, the team of Dr. Bosnan at Lausanne, Switzerland, has reported spectacular results on mice, cats, and pig. Here you can see in the upper images the results of flash irradiation on cat patient with locally advanced squamous cell carcinoma of the nasal planum. After 16 months post-irradiation, no acute toxicity and progression-free survival higher than 84% was noticed with the complete reconstruction of the nasal planum. In the lower images, there are the results of the irradiation of pig skins with doses in the order of 30 gray, with conventional and flash dose rate. While you can see fibronecrotic lesion for a conventional irradiated spot, the skin in flash irradiated spot appear as normal, even after having been irradiated with a dose rate of 300 gray per second. The same group of Lausanne has also reported the first treatment of a patient with flash radiotherapy by using a 5.6 MeV electron LINAC, a prototype LINAC, to deliver to a 75 years old patient 15 grays in 90 milliseconds for a multi-resistant cutaneous lymphoma. On the healthy tissue, no decrease of the thickness of the epidermis and a limited increase of the vascularization was noticed. And on the tumor, they saw a very rapid tumor response, durable, with a short follow-up of 5 months. All these preclinical studies were realized using as source different kinds of accelerators, essentially LINACs, and here you find few papers as reference: prototype linear accelerator or modified clinical linear accelerator, but also synchrotron light sources to produce X-rays, and cyclotrons to exploit the potential ballistic advantages of proton beams. Let's talk about the reference accelerator used by Dr. Favodon and Institut Curie. The S-band linear accelerator that was used for the original flash studies is named Kinetron and was designed and built by a French company, CGR-MEV, in the late 80s, with a view to investigate the kinetics of electron transfer and radical reaction in molecules at the microsecond timescale. It is a compact electron LINAC with nominal energy of 4.5 MeV and a set of parameters easily adjustable as the pulse repetition frequency and the pulse length. The kinetron is powered by a magnetron and is fitted with a thermionic triode electron gun. A precise adjustment of the grid potential of the triode allows a full control of the emitted current and pulse width in the flash mode. Particularly exceptional is the maximum dose rate that can be achieved during the pulse, in the order of 10 to the 7 gray per second. These parameters were used by a French company, PMB Elsen, to adapt the Oriatron ERT6 to provide the Lausanne team with a source to continue the studies on flash. As you can see, the main difference between these prototypes machine is the mean energy. That here is 1 MeV higher, so 5.5 MeV. To make a zoom on the differences between a flash irradiation and a conventional one, here we have a table summarizing few parameters. In particular, to achieve high dose rates, you need to increase the current from 1 to 300 milliamps, adjust the frequency and the grid potential of the triode. The main limitation of this prototype machine toward clinical trials is the low energy that is not enough to treat deep-seated tumor. Other groups has performed preclinical studies by modifying clinical accelerators, particularly the group of Professor Liu at Stanford and a group in Sweden. They basically use the LINAC without the Bremsstrahlung target and choose an intermediate position inside the treatment head, allowing a good compromise between dose rate, field size, and flatness. As you can see, the pulse repetition frequency for the two machines, depending on the energy, is in the order of 200 Hz, and the mean dose rate that they achieved is in the order of 200-300 gray per second. But still, the field size obtained are not enough to treat large volumes. As a matter of fact, the position chosen to ensure good field flatness and flash dose rates, the field diameter was less than 5 centimeters. The group of Lausanne investigated the flash effect using X-rays, 100 keV, from a synchrotron light source. They obtained the same results as using the 5.5 MeV electron on mice using a source capable to deliver 12,000 grays second in a slice with a mean dose rate in the order of 40 grays. You see that the accelerator current was in the order of 200 milliamps. But kilovoltage X-ray are generally not used for the treatment of deep-seated tumors. Other groups use cyclotrons and proton beams to investigate the flash effect. Particularly, our group at Institut Curie and a team from University of Pennsylvania, US, performed preclinical investigation using protons produced by isochronous cyclotron and using a passive scattering dose delivery system. In other words, they both needed to use scatterers to ensure a good dose homogeneity, sufficient thin to not influence badly the max dose rays, that was in the order of 100 gray per second. To avoid loss of fluence related to the beam transport, they both work at the maximum energy coming from the cyclotron, 230 MeV. As the frequency is around 100 MHz, the temporal structure of the beam is quasi-continuous. This is in contrast with the past structure of the linacs used to demonstrate flash effect with the electrons, but this seems not to be an issue. In particular, the UPenn experience showed a flash effect irradiating intestinal crypts, but the problem with the two facilities is that the irradiation surface that they achieved was not enough for clinical application. So the question now is how to translate these preclinical studies into clinical operation. From the accelerator point of view, we can say how to ensure the production of tens of gray in less than 500 milliseconds. The need is increase hundreds-fold the beam output of the machine that has to feed the existing volts, easy to operate and maintain, cost affordable, and that can be coupled with imaging devices for the patient positioning. Any idea? A group of Stanford Medicine and SLAC patented a solution named Phaser, pluridirectional high-energy agile scanning electronic radiotherapy, to deliver megavoltage photons and also very high-energy electron beams. Let's have a look at their proposal. To answer the question how to achieve hundreds-fold greater beam output than conventional medical linacs, they propose the use of new accelerator science to design highly compact, economical, and power-efficient linear accelerator and radio frequency power sources. They named this accelerator structure as Dragon, distributed RF coupling architecture with genetically optimized cell design. The idea is to distribute the RF power to each cell independently without coupling between cells, allowing a higher shunt impedance, a higher repetition rate, and a higher efficiency, 80 versus 20%, than conventional linacs, and this solution is patented by Stanford. In order to fit Phaser in the existing treatment vaults, they propose the use of a compact RF phase array power distribution network of waveguides. 16 input ports combine the power of 16 modular klystron that are named klystrinos because of their small sizes. They direct the total power to any of the 16 output ports connected to 16 stationary beam lines providing a full complement of non-coplanar beams for highly conformal radiotherapy without mechanical gantry rotation. This modular class 3 nodes has a low voltage operation and a high peak RF power. They are highly efficient and they allow an overall reduced cost. From a more clinical point of view, to answer the question to how to perform beam intensity modulation without a multi-leaf collimator, they propose the use of a dedicated electron beam scanning system, the scanning pencil beam high-speed intensity modulated X-ray source Sphinx. The electron beam is scanned on a stationary Bremsstrahlung target to produce megavoltage rays and a collimator array, eliminating the need for mechanical collimator motion. And to perform the positioning imaging during the treatment, they also propose the integration of a full ring diagnostic quality speed multi-detector CT, sharing a common isocenter with the non-coplanar treatment beam lines. To conclude, the solution from the Slack-Stanford team suggests that R&D on accelerator and RF power design can make radiotherapy more affordable and explore the potential advantage of flash irradiations. Cost reduction and compactness can be ensured by multiplexing the RF sources so that the peak power from each source can be reduced, and high clinical efficiency can be obtained by combining multiple LINACs with CT for the motion management. The same team also proposed a system to deliver very high energy electron flash radiation therapy. Technically, they suggest the production of a specially patterned electron source produced by projecting an optical image onto a photocathode. The electron image is then accelerated intact through a A-gradient Dragon LINAC and steered and magnified to treat the treatment volume, producing an intensity modulated treatment field. This solution is motivated by the much lower beam current needed when treating directly with the very high energy electron, as no Bremsstrahlung target is needed, and by the potential advantages of using VHEE in radiation therapy. The idea of very high energy electron for radiation therapy was proposed by de Rosier in 2000. The predicted advantages of VHEE relies on the depth dose profile, so they can ensure the treatment of deep-seated tumor with a flatter profile than photons, the reduced lateral scattering, so the low penumbra, and the possible magnetic collimation allowing scanning the target, and a low sensitivity to heterogeneities, so no electronic disequilibrium interfaces. Thanks to recent high-gradient LINAC technology developments like in CLIC, VHE could be a cost-effective option in radiation therapy and open up innovative treatment modalities like flash or special fractionation of the dose like grid mini beams. Very recently, beam dosimetry studies for very high energy electron have been realized at different research facilities, like CLEAR CERN with a 200 MeV electron beam, or at the Next Linear Collider Test Accelerator at SLAC, with beam ranging between 60 and 120 MeV, or at SPARC at TNFN Italy with a 165 MeV beam, at Elbe in Germany, or at Alpha EX with a 135 MeV laser plasma wake field accelerator. But as far as I know, in vivo experiments have not been performed to date with very high energy electron. This is a fundamental step toward the validation of the use of very high energy electron as a treatment modality, even before to think about it to perform flash irradiations. And to conclude, another important parameter is the temporal structure of the beam. As you have understood, the best source for a flash radiation therapy is not yet known, but you have to deal with high dose in the pulse and ultra-fast irradiation times. When you look at the different temporal structure of the accelerator potentially available to deliver flash irradiation, very high energy electron, RF-driven, seems to be a better candidate with respect to laser-driven electron beams. So even if the development of compact laser plasma wake field accelerator could be promising in the field of very high energy electron, they won't probably provide a flash effect as long as the dose per pulse is low and the total length of radiation exposure exceed the 500 milliseconds, even if they have an extreme high dose rate in the pulse. So the flash RT studies have proved an increased therapeutic index enabling higher doses to be tolerated by normal tissues. Multidisciplinary teams are working to provide further studies to fully define the impact of total dose, temporal patterning, total exposure rate, radiation quality, and the fundamental biological mechanism. As shown with the phaser system, the accelerator community could play an important role in the development of alternative solutions to provide flash irradiators. And for future clinical trials, it has to be defined how to irradiate large volumes in less than 500 milliseconds with a consistent dose, and protocols for beam calibration and absolute dosimetry, as started with the IPAC consortium. So thank you very much for your attention, and I would like also to thank all my colleagues and the collaborators helping me in realizing this work. Merci.